My name is Alan Ng. I'm a podiatric foot and ankle surgeon based out of Denver, Colorado. I practice at Orthopedic Centers of Colorado. I've been here for 23 years. My focus in my practice is sports medicine and foot and ankle reconstruction, everything from simple forefoot surgery to total ankle reconstruction and revision surgery, as well as soft tissue reconstruction, where we use a lot of the hyaluronic acid-based scaffolds to improve our patients' outcomes. So soft tissue problems that we see in foot and ankle, a lot of times it's based on healing. We know how to do the surgeries. We know how to reconstruct tendons, ligaments, soft tissue. The problem is we don't have a good control over the patient's own biology. So anything we can do to enhance the biology of the patient to get a better surgical healing and a better surgical outcome is very important. And if we're able to do that by using something to improve the biology, decrease some of the variable factors that we see on a regular basis with each patient's different healing potentials, that's a positive in my surgical hands. So tendons in the foot and ankle that seem to be problematic, the two main ones that come to mind immediately are the peroneal tendons and the Achilles tendon, both of which can be very variable with the amount of healing. With peroneal tendons, one of the main things we deal with a lot of times is reconstructing or repairing, say, a longitudinal split tear. And the tendon may still be intact, but it's degenerative. There's mucoid degeneration, there's hypertrophy of the tendon. So you're going in there and trying to sew this split tear back together, and it's already a thick tendon. So the biology there has failed. You have enzymatic degeneration secondary to mucoid degeneration. So you have to go in there and repair this, but you want to be able to allow the body's ability to enhance your healing to be there. And by using some sort of scaffold to give it a scaffold to grow into, and also avoid inflammatory factors that cause the tendinosis would be important. The Achilles tendon is always tough. After every single Achilles rupture or insertional Achilles tendinopathy repair, you're going to get scar tissue, no matter what you do. No matter how good of a surgeon you are, no matter how well you repair that tendon, it's going to scar. If you can avoid or decrease the amount of that scar tissue or enhance the ability for that tendon fibers to grow in a more longitudinal oriented fashion, you'll get a better surgical outcome. Versus, when you see an Achilles tendinosis or damaged Achilles tendon, it's a balled up, non-elastic hard mass. Same thing occurs when you repair Achilles tendon and pull it back together. It is hypertrophy. So if you can enhance the ability for that to heal and decrease that hypertrophy, you have a win. So anything we can do to do that will be beneficial. So in any immunocompromised patient, we're talking about diabetics, rheumatoid arthritic patients, metabolically insufficient patients that don't have the proper nutritional metabolic state in order to heal appropriately, patients with gastric bypass, patients that essentially are smokers, or patients that are malnourished, whether it be self-induced or from some other comorbidities. Those patients don't tend to heal as well. And if we can enhance ability for the tissue to heal so that you decrease your risk of failure of growth, dehiscence, all those type of things, that'd be optimal. I've been augmenting tendons since I started out of fellowship back in 2001. God, it's been a long time. So, but augmentation products have been limited, right? Over the years, we've had things like dermal grafts, had things like added no-stretch sutures. There really hasn't been a good biologic that gives a good scaffold. There's been some collagen products that tend to help and give some kind of scaffold for, aligned collagen fibers to grow. But there hasn't been something that's been a scaffold and also a biological enhancement, something that increases the environment. It's usually one or the other. You have a lot of amnion type materials that don't give you any structure or any real true scaffold. They just bring a little bit of biology in the area. Now we're talking about hyaluronic acid type of material that we know modulates inflammation, anti-inflammatory, has biological response to increase the ability for the body to heal in that area. So a combination of that with the scaffold that goes away over time is ideal. We don't want bulk. The problem with dermal allografts in the past we used to enhance tendon repair is that they're bulky and they stay there. So you may give some strength, but now you have a foreign body that's thick and is problematic long term. It's been a few years now. I think we started using the initial small patch, and it's progressively increased over the years. The most striking outcome to me is immediate post-op swelling. They don't seem to respond to have the massive amount of swelling post-surgically, and then when the tissue does heal, the long-term ability for that tendon structure to heal doesn't seem to be as, I guess you call it tight, right? Tight or scarred. It seems to be more mobile and has improved the ability for the body to heal that in a better aligned fashion versus a haphazard collagen matrix. So I think that's what I've seen more over the last few years using Integrity, and and looking at the product further. You grab the Integrity patch, you're like, oh, this is a structural scaffold, it's got to be super solid. But in reality, it's not a structural scaffold. It's a scaffold that allows ingrowth, that also has a biological component that, as it incorporates, it releases its ability to enhance healing and decrease adhesion/scarring, in my opinion. It's a physiological material that's natural, right? It's not necessarily something that's synthetic. It's not something that is an allograft or a xenograft, but it's something that the body recognizes as not foreign. So the body doesn't react to it, and it has inherent principles as it resorbs for biological healing. So anti-inflammatory, induction of healing in the area, more non-scarred collagen formation is the reason why we lean towards this more of a biologic product that is not reactive or not foreign to the body. And it helps with the inflammatory modulation, it helps with healing, which a lot of the other products had scaffold but didn't have biology to it, or something had biology, didn't have scaffold. So this kind of bridges the gap between both those problems. A partial tear is still a partial tear. So sometimes partial tears hurt more than full tears because they're still somewhat attached. So a partial tear or a longitudinal split tear, like in a peroneal tendon, that area is sometimes more difficult to heal than a complete tear, right? Because that area gets hypertrophied, it's thickened, and it's like pulling a thread on a seam. It gets bigger and bigger and bigger. We need to lock that down, heal it, and get it to heal back as biologically as best we can. The majority of the Integrity is mostly high half, which is what I want, right? The PET is there, and I have not seen any foreign body reactions or any reaction to that tissue. And I sew my Integrity in. I'll untubulate a tendon, and I'll sew with the absorbable suture, and I don't really see any bulk afterwards, right? That was a problem we saw with a lot of the nose stretch sutures or a lot of the dermal allografts. Is the bulk afterwards. There's no bulk with this. Once it's sewn in, it may look bulky initially, but we know that's gone after a few months. And the biological component's still allowing it to heal in that area. So I'm not worried about foreign body reaction. I'm not worried about bulk in there afterwards. I just want the healing. As we see further growth in our technology and our development of these products utilizing HIAF as a base, I think usage will go up over time as we increase the amount of things we can use, whether it's a patch, whether it's a suture, whatever it may be that we use with this HIAF technology. I think it's something that will hopefully become more mainstream and give us better patient outcomes. Meaning that we know it's a product that is not going to be stuck there forever. It'll go away over time. While it does that, it enhances the biological environment of the repair site. If we eventually develop a suture that has a HIAF in it, even more so, I can see that in every single repair, right? Because right now we're using a nose stretch suture or a high tensile suture material, whether that be a fiber type stitch that is permanent. Now you're talking about a suture that crosses the rupture or tear site that will also enhance the ability for that repair to heal faster and better. Using the Integrity now as we intubulate our tendons or lay it as an on-leg graft over the outside gives us that environment. Now we add stability with biology. That's the next game changer. And as we develop some technology and develop some products to do that, I mean, they could be a huge game changer in the sports medicine and tendon repair type of pathologies that we deal with. In the past, we've had a certain smaller footprint patch that we've used to repair these tears, and a lot of times the patch wasn't quite large enough. We're still able to intubulate some of the tendons on smaller tendons. The bigger tendons, we always had difficulty with sew them together, onlay it, and a lot of it's based on what was given to us based on the anatomy. Now there's bigger patches coming out, and as we start using that more, we're able to really engulf or circumferentially cover the tear. That's what I think that's important. If we can do that and keep that environment where that tendon is healing engulfed in the biological improvement of that area that should hopefully make a difference in some of our repairs and our return to activity type of things in our patients. With Achilles ruptures, I know a lot of the technique currently is using a lot of percutaneous approaches. Even then, with the onlay, you could slide this underneath the small incision and lay it over the sutures, hopefully, and that would be the goal, to try to use that to repair some Achilles tendon ruptures, and maybe use that to kind of slide it. I like sliding it behind the repair site, so it's not tension against the skin. But I know that's gone, so if I can push that underneath and decrease the edema in that repair site, that's important in my hands. We're talking about insertional Achilles tendinopathy. I like to put the integrity between the bone and the tendon. Well, you asked to pose the question, doesn't that get in the way of the healing? No, because the HIAF is going away and absorbing and creating a biological environment for that tendon to tack back down to the calcaneus, and do that in a less inflammatory way. So those are kind of ways to do it now with the current patch we have. Now that we have the larger patch coming through, and start using that more and more, we have a better ability to intubulate tendons easier. Now that we have a larger footprint, that's exciting. The integrity itself, do I use it all the time? No. A lot of times I'm counting on the HIAF alone, and that does a good enough job. Now, if I have a really bad chronic recurrent tear or something that's problematic, that's high risk, yeah, I'll pull some bone marrow aspirate and soak the integrity in that. You can even use PRP and enhance the growth factors in that area. I think I've done that a couple times and had some good results. But a lot of times, when we're repairing a tendon, it's speed, right? You want to get in, you want to fix that tendon, you want to repair that, and you don't think necessarily about enhancing the integrity with a biologic. But in certain cases, when you have really bad tendinosis or really bad recurrent injuries to the tendon, it may not be a bad idea to utilize a biologic enhancement on top of the biologic enhancement you already have. So now you're kind of supercharging that area. So that's another option as well. And the cellulations needle, using that to aspirate, this makes it easier, so you don't have to spin it down. You essentially use the cellulations needle to aspirate and get the best growth factors from the bone marrow aspirate. Concentrating it that way is a seamless and quick way of doing that. I'm still pretty standard. I still try to mobilize them as fast as possible, but what I'm seeing is less edema, less post-operative swelling. I'm still pretty stubborn. I'm old, so I stick to my ways of how I treat my tendons post-surgically. I haven't really pushed the limits on the post-op, like getting them going faster. I still ambulate my insertional Achilles rupture treatments, my insertional like spur fixation. I still walk them at 3 weeks. That's still pretty early. My Achilles rupture repairs is 3 weeks as well. Peroneal tendons 3 weeks, so they're walking pretty fast. So I'm not keeping them off for 6 to 8 weeks. I'm a 3 week kind of guy with soft tissue. The hopes are that 3 weeks allows that soft tissue to attach back to each other. Obviously with increasing the biologic environment, that probably does help. But I still keep the same protocols when I'm doing that. I saw a patient today. I did a os perineum excision 3 weeks ago. And he showed up again this 3 weeks, says, I had zero pain. His wound looks amazing, which, he's healed. It looks awesome. And he's in PT and wants to walk on it. He's moving on it right away. I'm like, didn't we just do your surgery 3 weeks ago? He goes, yeah, it's been the easiest. And I'm like thinking, what the heck? Oh, wait, so it was one of the first, I was going to use a bigger patch. I didn't need to. By the time I got down to the os perineum and the tendon was thinned out, I saw how thin that was after I took out the os perineum. I intubulated that little distal portion that comes right under the cuboid. I took the os perineum out, and I circumferentially carefully wrapped the integrity around it and sewed it to the tendon and intubulated it. I didn't realize that till after I looked at it today. I was like, why the heck is he doing so well? And oh wait, that's right. I sewed in a scaffold on this one. So we're busy. We forget sometimes what we did to enhance our surgeries. And then you go back and look at what did I do? Oh, no wonder they're doing so well. So, to be honest with you, we expect these patients to do well, right? So when we do these surgeries, we want these patients to improve and recover quickly. So anything we can do to enhance their ability to get back on their feet again, enhance their healing, we do. So now it's almost seamless. I go in there and do a repair, and it's like, oh, you're doing awesome. That's great. I expect that. So if it wasn't going well, and I look back at the chart, and like, did I do something? Did I forget to do something? Did I not sew in integrity in? Or that's when you start pondering these questions. But when I look at these patients, like today, I was like, God, I don't know how you're doing so well. And I look back and go, oh, that's right. I sewed a scaffold into his distal repair. I like to think it's surgeon technique more so than biology, but I think the integrity patches are pushing the odds in my favor a little bit. What I would say is, what would you want in your repair? If you had a torn tendon and you wanted something repaired, do you want just somebody to go in there and sew it together, or do you want enhanced ability for your tendon to heal in this most optimal manner, right? So if you could get a better post-surgical outcome, even if it's just decreased pain and swelling, wouldn't you want something in there to improve your surgical outcome? And that's the way I look at when I'm using bone grafts, when I'm using orthobiologics, when I'm doing tendon repair. What would I want in my tendon to improve the outcome of this repair? I guarantee you, if I had a cuff repair, I would definitely have integrity in my cuff, and my left one's probably going pretty soon too anyway, so that could happen, so what would I want? Yeah, would I want something in there, or just go ahead and sew my cuff back down and put a couple anchors? It's a no-brainer. You got to have biology these days with technology and the way we're looking at repairs and how things heal. The ability to enhance the biological environment for soft tissue, for bone, for whatever it may be, with this technology these days, and all technology these days, for any type of surgical intervention, there's no reason why you shouldn't augment these. And in this case here, you want a product that you can trust for scaffold and for biology. There's always the discussion of cost and all these things, and you look at some of the other scaffolds out there, we're reasonably priced, and it's ASC friendly, it's hospital friendly, and it works. So why not enhance your ability to improve your patient's outcomes versus not doing anything, right? Surgical repair, but healing's a whole different game in that case. You don't know if it's going to heal, or you don't know if it's going to heal well. Why not try to make it heal well instead of just getting it to heal together?